Everyone. My name is Dr. Zishan Ahmed. I am a pediatric intensivist from Rani Hospital, Ranchi, and the topic for today's presentation is management of congestive heart failure and cardiogenic shock. So, before I begin, I'll let you know my resources from where I am bringing you this presentation, mostly from Rogers Textbook of Pediatric Intensive Care 6th edition, which is the latest edition, and also from Pediatric Intensive Care Protocols of AIMS New Delhi, the latest 8th edition, and the OPCHI Essentials of Pediatrics, the latest 10th edition, and also a part of ECMO, for which I am gone through the ISCCM Manual of RRT and ECMO in ICU, the 2nd edition. A brief overview of what we are going to deal with in the coming slides. So, first of all, the definition of acute heart failure and cardiogenic shock, and the etiology, the pathophysiology, the signs and symptoms. And we need to go through the etiology and the signs and symptoms, because before understanding the treatment, we should understand all these things. Otherwise, we'll not be able to understand which drug is being used for what purpose. After that, we'll proceed to the investigations and then the treatment. We'll mostly deal with the medical management part of congestive heart failure, and a little bit we'll discuss about the mechanical support devices like the ECMO and the VAD. So let's begin. First of all, the definition. So the definition of acute heart failure, it encompasses two entities. The first one is the acute decompensated heart failure, which is defined as rapid onset of or change in signs and symptoms of heart failure. So it might be a sudden onset of acute heart failure, or it might be that the patient is suffering from a chronic heart condition and suddenly there is an acute decompensation of the chronic heart failure. And about cardiogenic shock, it is defined as a state in which oxygen delivery to the tissues is insufficient relative to the body needs. This is the general definition of shock. But the most important here, that it needs to be secondary to poor cardiac function. This is important. This secondary to poor cardiac function is important for cardiogenic shock. And this definition has been given by the European Society of Cardiology in the year 2012, which we are following here. Next, we will discuss about the etiology. So, whenever we talk about heart failure, we usually talk about only the systolic dysfunction of the heart, but a very missed part of it is the diastolic dysfunction also, which can also lead to heart failure. So, most of the cases what we get of acute heart failure is all due to systolic dysfunction, and in pediatrics there are three major causes. Unlike in adults, ischemic heart disease is the most important cause, but in pediatrics, ischemic heart disease is not found much. So the three main important causes are structural heart disease, or any myocardial heart disease, or any rhythm disorders or arrhythmias. So first, let's go through the first one, the structural heart disease. In structural heart disease, acute heart failure can occur due to three conditions. The first one is volume overload, the second one is pressure overload, and the third one is due to any complex congenital heart disease. Under volume overload, it can be due to any congenital heart disease which has left to right shunt, like ventricular septal defect, atrial septal defect, and patent ductus arteriosus. And it can also be due to some regurgitant valvular lesion, like mitral regurgitation, tricuspid regurgitation, pulmonary regurgitation, or aortic regurgitation. The next important aspect of structural heart disease is due to pressure overload. So it can be either right ventricular outflow tract obstruction or due to left ventricular outflow tract obstruction, which will lead to pressure overload over the heart. So RVOT obstruction can be due to pulmonary stenosis or peripheral pulmonary stenosis. And the left ventricular outflow tract obstruction can be due to critical aortic stenosis, or furthermore, we can go down the aorta. It can be due to critical coaptation of aorta. Now, there are certain complex congenital heart disease which also present with acute heart failure, but the mechanism here is slightly different from the others. So, like corrected TGA, truncus arteriosus, and single ventricular physiology, all these conditions can present by acute heart failure. To give you an example, like in corrected TGA, the right ventricle is acting as the systemic ventricle. So the right ventricle has to pump blood to the body. But anatomically, the right ventricle is not as muscular as the left ventricle. So it does not have so strong contraction that it will push the whole blood into the brains and towards the feet. So what happens, because the muscle mass of the right ventricle is less than the left ventricle, it cannot act as a systemic ventricle, and in due course of time, the right ventricle starts to fail in corrected TGA. This is one of the mechanisms which I just gave you as an example. So these were the three mechanisms by which structural heart disease can lead to heart failure. Coming to the myocardial heart disease, it can be due to any cardiomyopathy or due to any systemic disease. Under cardiomyopathy, we know that there are three most important popular cardiomyopathies. I have added myocarditis here. It is not actually a cardiomyopathy, but it involves the myocardium. It's a myocardial disease. That is why I have included myocarditis in this list. So myocarditis, mostly due to viral infections, or might be due to some toxins or drug ingestion. And the other three cardiomyopathies, like dilated cardiomyopathy and hypertrophic cardiomyopathy and restrictive cardiomyopathy, all of these can lead to systolic dysfunction. You can find that there are asterisk marks over HOCM and restrictive cardiomyopathy. That is because these two conditions have both systolic and diastolic dysfunctions. It is not purely systolic dysfunction. So these are the myocardial conditions in which systolic dysfunction and heart failure can occur. So coming to systemic diseases, these are a lot more common encountered in our ICUs. The most common is sepsis or septic shock, which can lead to cardiac dysfunction and acute heart failure. The other common conditions are systemic hypertension, which will lead to left ventricular failure, and pulmonary hypertension, which will lead to right ventricular failure. And after any cardiopulmonary resuscitation, there will be cardiac dysfunction. And also we have to exclude thyrotoxicosis and vitamin D deficiency, which primarily can cause systolic dysfunction and acute heart failure. And it can also worsen if there is a cause of heart failure, acute heart failure. If there is vitamin D deficiency or the child is suffering from hyperthyroidism, it will aggravate the heart failure. Coming next to the rhythm disorders, we know that dysrhythmias or arrhythmias can be classified into tachyarrhythmias and bradyarrhythmias. So amongst tachyarrhythmias, supraventricular tachycardias and ventricular tachycardias, these can lead to heart failure. And among bradyarrhythmias, any kind of heart block, the primary, secondary or complete heart block, and any rhythm apart from the sinus node. That is any sinus node dysfunction where the rhythm of the heart is taken over by some other tissue like the AV node or the nodal rhythm, like the junctional rhythm or the atrial rhythm where the signal originates from the atrial musculature. So these are the major causes of heart failure in pediatrics, and mostly it is due to systolic dysfunction. But there are certain conditions in which the diastolic dysfunction of the heart leads to cardiac failure. Now let's look what are those conditions. Mostly we get constrictive pericarditis and pericardial tamponade. If there is pericardial effusion or hemopericardium or pyopericardium, and so it can lead to cardiac tamponade. And there are two other conditions which we discussed earlier, like restrictive cardiomyopathy and hypertrophic cardiomyopathy, which can lead to diastolic dysfunction, and they have components of both systolic and diastolic dysfunction. So that was all about the etiology. Coming next to the pathophysiology. The pathophysiology of acute heart failure and cardiogenic shock is very similar to any kind of shock. So there is a concept of oxygen supply or DO2 and oxygen demand of VO2. So DO2 is the delivery of oxygen to the tissues per minute, and VO2 is the extraction of oxygen from the blood by the tissues per minute. So if the demand of oxygen by the tissue increases or the supply of oxygen in the blood decreases, it will lead to symptoms of shock. And if it is due to cardiac dysfunction, then it is cardiogenic shock. So the oxygen supply or DO2 depends upon two factors. One is the arterial oxygen content and the other is the cardiac output. Now, the arterial oxygen content depends upon a few factors. One is hemoglobin concentration. So, if the child has anemia, then it will aggravate or it will decrease the oxygen supply to the tissues. And next is the hemoglobin saturation. If the available hemoglobin is not saturated enough by oxygen, then it will lead to lesser delivery of oxygen to the tissues. The other conditions are alveolar hypoxia and shunt fraction, which can occur due to any lung conditions like pneumonia, ARDS, empyema, etc. Coming to cardiac output. Now, cardiac output depends upon two factors. We know that it's a product of heart rate and stroke volume. So, either of this, if it gets affected, it will lead to decreased cardiac output. So, heart rate can be affected by a variety of factors. For example, catecholamines, endogenous or exogenous, and arrhythmias. And stroke volume is dependent upon three factors. Preload, that is the volume status of the body, the contractility of the heart, and the afterload, that is the systemic vascular resistance of the body. So that was all about the oxygen supply or the VO2. Coming to the VO2 or the oxygen demand. Oxygen demand can increase in a variety of conditions. One is the first one is resting energy expenditure, or the BMR. If the basal metabolic rate of any person is very high, then it will consume more oxygen. And the other is exercise, fever, due to pain and anxiety, and if there is increased work of breathing due to any lung conditions, and if there is inadequate sedation while the patient is being, for example, mechanically ventilated, then it will all lead to increase in the demand of oxygen or increase in VO2, and it will aggravate the cardiogenic shock or acute heart failure. So, coming to the symptoms, or what symptoms the child comes to us on history. So, it differs a bit amongst neonates and infants and from those of older child. Amongst neonates and young infants, the 4 or 5 most common symptoms of heart failure is like the child is breathing too fast and he or she breathes better when held against the shoulder, which is analogous to orthopnea in an older child or adult. Again, the other common complaints are difficulty in feeding and a bluish discoloration of the body and poor weight gain, and a child who is irritable all the time or is constantly crying. Like most of us usually suspect infantile colic when a child with excessive crying comes to us, but it can also be due to any heart condition or lung condition or sinus condition. So any child who is crying incessantly should be examined thoroughly on the systemic examinations, because heart failure can also present with this complaint. And points to be asked for or looked for in the history, especially important is the feeding history. So we should know the volume of feeds and the time to completion of feeds. So if the volume taken is very low and the time to completion of feeds is very long, then it might be due to heart failure. And if the child is sweating a lot during feeding, and there is suck cycle present, like the child is very hungry, starts sucking, then he gets tired, then he leaks the breast, and then he again after some time he starts sucking again, and this cycle continues. It is known as suck cycle. If this history is present, it might be due to heart failure. Other important thing in history is the perinatal history. So we have to inquire about birth, asphyxia and maternal viral illness, and maternal diabetes or exposure to lithium and alcohol or NSAID during the pregnancy. And family history is very important, because there might be some family history of congenital heart disease or any cardiomyopathy or any arrhythmia or any sudden death in the family. There might be history of any muscular dystrophy or any muscular disease in the family, which is very important to us. So this was about the neonates and young infants. Coming to older children, in older children, the symptoms of heart failure are very vague and non-specific. So it is very difficult to suspect heart failure. in an older child, because the first non-specific symptoms are like fever and excessive spitting, sweating, and poor growth and facial puffiness. These are very non-specific. And the other present complaints might be, you might think that is it is due to some respiratory or GI cause, because the complaints will be like difficulty in breathing and cough, chest pain and wheezing. And if you think about all these can literally point towards the respiratory system, so you might be confused. Even GI symptoms are very common in heart failure, like nausea, vomiting, abdominal pain, diarrhea. A child with heart failure can often present in these symptoms. So again, you might be confused that this is some GI condition, but it is primarily due to the heart disease. And sometimes, very rarely, he can also present with syncope or seizures. So we might think that this is due to some CNS disease. So complaints and symptoms of heart failure are very non-specific, and it might point to some other system. So a very high index of suspicion is necessary. Next, coming to the signs, what you will find on examination. There's a very beautiful algorithm or table given in OP Guide Essential of Pediatrics. So it, first of all, it discusses signs which are common to both ventricles failing, like cardiac enlargement, gallop rhythm, or when the third heart sound can be heard, peripheral cyanosis, feeble pulse, and lack of weight gain. These symptoms are common whether the right ventricle fails or whether the left ventricle fails. Now, coming to individual ventricles. If the left ventricle fails, it leads to pulmonary congestion. So mostly respiratory symptoms will predominate, like tachycardia, tachypnea, cough, wheezing, and basal crepitations or oscillation. Now, if the right ventricle fails, it will lead to systemic congestion, and symptoms and signs will be like hepatomegaly, facial edema, and the jugular venous pressure will be raised, and there will be pedal edema or sacral edema or dependent edema, whatever. But mostly there is a concept which you should know. It is known as ventricular interdependence. What it means actually is, if one of the ventricle is failing, ultimately the other ventricle will also fail. Like if the left ventricle is failing, it will lead to pulmonary congestion, and due to back pressure, even the right ventricle will also fail. Again, if the right ventricle is failing, it will lead to pushing of the interventricular septum to the left side. So the contractions of the left ventricle will also decrease, and the left ventricle will also start to fail. So these signs are not found individually for both ventricles separately. Most of the times, all these signs you get together in one child. So both of the ventricles have failed. Coming to the investigation part. First of all, we'll discuss the laboratory investigations. In our hospital, whenever any child comes, we do some basic investigations, like complete blood count. And here we should look for the hemoglobin concentration, because anemia, any kind of anemia, will worsen the heart failure. Next is the CRP, which, if it is increased, is a very good clue to sepsis. Again, blood culture and sensitivity is the gold standard for sepsis, and sepsis can lead to cardiac dysfunction. We also have a venous blood gas done for every admission, and here we have to look for any dyselectrolytemia like sodium, potassium, calcium. If they are deranged, we have to correct them, because they can also lead to worsening of the heart failure. And lactate, we have to see the lactate levels, whether the peripheral circulation is good. And urea, if the urea is increased, then there might be some prerenal AKI due to volume depletion due to heart failure. One very important marker is the N-terminus probenatriuretic peptide, or NT-proBNP. If it is increased, it's a very good marker of cardiac dysfunction or heart failure. And it is a very good marker to differentiate between respiratory distress of cardiac versus pulmonary origin. And it has prognostic value also, like the trend is very useful to monitor the disease progression and the response to treatment. So these are the basic investigations which should be sent at admission, because we don't want to overburden the patient with lots of investigations at the time of admission. So these are the basic investigations. However, there are certain other investigations which we should think about in due course of time during the treatment process. First one is viral serology. That is the serum and respiratory specimens, especially for enterovirus, adenovirus, parvovirus and influenza virus, which are very common in myocarditis. We can also do liver function tests and kidney function tests to look at any organ damage. There are certain other biomarkers apart from NT-proBNP like cardiac troponins, TNI and CKMB enzyme, but these do not give any additional information. We can also think about doing the serum vitamin D levels and the thyroid function tests, because if there is hyperthyroidism or vitamin D deficiency, it can lead to aggravation of the already existing heart failure. And again, if we are thinking about some metabolic disorder or any genetic disease, we can do in any IEM screen or any genetic test to diagnose the condition. But these tests we have to discuss with our consultants and colleagues during the course of treatment, whether that child needs these tests, some of it or all of it. Coming to the imaging and any invasive tests. 3 investigations which should always be done in case of heart failure. One is the chest X-ray, the other is the 12-lead ECG, and the third one is the 2D echocardiography. In the chest X-ray, what we do, we want a PA view if it's an older child and an respiratory film, but it is not always possible in case of infants or younger child, so even an AP view will do. We will measure the cardiothoracic ratio, and if it is greater than 0.55, and some books write 0.6, if it is greater than that, then there is cardiomegaly, which is a pointer towards heart failure. We should also look at the pulmonary veins, venous prominences in the lung fields, and if it reaches the lateral 1/3 of the lung, then it's called pulmonary plethora, which is again a sign of heart failure. And also we should not confuse the thymic shadow with the heart, because the thymus is sometimes present very prominently in young children, and it might look like cardiomegaly, but it is just an enlarged thymus. 12-lead ECG should always be done to detect any arrhythmias. Especially we should look for the voltage of the QRS complex and any ST and T wave changes, which are very common in viral myocarditis or myocarditis due to any cause. 2D echocardiography is also very useful, and it should always be done because it will detect any structural defect or any congenital heart disease. And functional echo is also very useful at bedside because we can know about the stroke volume or the contractility of the heart. Now there are certain other invasive tests and certain special tests like cardiac MRI, which tells us a lot about the structure and function of the heart, but it is very expensive. The cardiac catheterization, but it can only be done in centers equipped with cath labs, and cardiac biopsy, which was the base of the Duke's criteria, but it is no longer done after the advent of MRI machines because it is very invasive. Coming to the principles of management. So the management of congestive heart failure can be divided into 2 parts. First is the medical management, the other is mechanical ventilatory support, which is used when the medical management fails. So the MCS, or the mechanical ventilatory support, consists of 2 processes or 2 therapies. So the first one is extracorporeal membrane oxygen therapy or ECMO, and the second one is ventricular assist device or VAD. But mostly here we will be talking about the medical management part of the CHF. So let's talk about the medical management. We have already gone through this flowchart or algorithm during the pathophysiology phase. Now we should understand how these things work to lead to heart failure. So if the oxygen demand, so how will we manage heart failure? We should try to decrease the oxygen demand of the heart, of the body as a whole. So No exercise, strict bed rest, any fever should be controlled. There should be no pain and anxiety. Again, about the oxygen supply, we should try to increase the oxygen supply to the body and to the heart. This can be done by increasing the arterial oxygen content or by increasing the cardiac output. We should ideally try to increase both of them. So, the cardiac output now depends upon the heart rate and the stroke volume. The heart rate should be optimized. It should not be very high. It should not be very low, because in extremes of heart rate, the cardiac failure worsens. Stroke volume is dependent upon the preload. Preload should also be optimized, because at very high preload or high intravascular status, there the cardiac output or the cardiac dysfunction worsens and the heart failure worsens. Or if there is very low preload of the heart or the venous return, then again the cardiac output decreases. So the preload should be optimized to normal. The contractility should also be optimized to normal. It should not be a very hypercontractile heart, or the contractility should not also be very poor. And the afterload or the peripheral vascular resistance should decrease, except in cases of septic shock where it might need to be increased, but in all other cases the afterload should be decreased. Now, we will discuss about the ways to decrease the metabolic demands. First of all, the very important and very overlooked step, which is the control of fever. Because the total oxygen consumption by the body increases by about 10% for every degree Celsius rise in temperature. So we have to use antipyretics like paracetamol very frequently to keep the temperature in the normal level. Another very useful adjunct is positive pressure ventilation. What it does, it unburdens the diaphragm and the respiratory muscles, so they don't have to work anymore. So that it reduces the total oxygen utilization by the body. And addition to that, it also reduces the afterload of the left ventricle, so it improves the symptoms of heart failure. By PPV or positive pressure ventilation, I mean either invasive or non-invasive ventilation. Both can help in case of heart failure. And again, very important point, sedation and analgesia. If a baby or if a child is ventilated, then he suffers from a lot of pain and anxiety. So we have to give analgesics and sedatives like ketamine and midazolam infusion. But what they do is that they blunt the endogenous catecholamines and they increase the venous capacitance of the body, which leads to peripheral pooling of blood, which decreases the preload to the heart. But there is a major side effect. It may also depress the myocardial contractility of the heart. So we have to use the minimum sedation possible. And during intubation, the most experienced person should manage the airway, because intubating a child with heart failure is very difficult. They tend to desaturate very quickly. Unlike in CNS disease, any condition with respiratory or cardiac involvement will desaturate very quickly. So the most experienced person should handle the airway or intubation. Now we'll discuss about the ways to increase the arterial oxygen concentration. One is packed red cell transfusion. We should aim to keep the hemoglobin above or at least 10 gram per dl. And the transfusion should be very slow and under the cover of diuretics. We also should increase the supplemental oxygen to the patient. We should try to give 100% oxygen using high flow nasal cannula or CPAP machine or non-invasive ventilation. And in extreme cases, invasive ventilation can also be tried. If invasive ventilation is needed, we should target a higher PEEP or higher FiO2. And in addition to this, we should also treat the lung conditions if it is present, like pneumonia, like ARDS, empyema, pneumothorax, collapse, consolidation, etc. Because if the lungs are not functioning well, the oxygen will not be transported to the blood. So it will lead to decrease in the arterial oxygen concentration. And head end elevation, we know about the importance of head end elevation in cardiac cases or cardiac failure cases. Because what it does, it reduces pulmonary edema and it leads to peripheral pooling of blood into the legs, so it decreases the preload to the heart and it improves the symptoms of heart failure. Now, we should also try to optimize the heart rate to the near normal levels. We should not use too much of catecholamines like adrenaline, and too much of dobutamine also. Because if we increase the inotropy or chronotropy, the heart rate will increase and there will be very less time for diastole. So it will lead to worsening of the heart failure. There are novel drugs like milrinone and levosimendan which can be tried, which are very lusitropic. What lusitropy means, it allows the heart to go into diastole. So it will improve the systolic as well as the diastolic function of the heart. Any kind of arrhythmia should be managed, because if not managed well, it will lead to worsening of the heart failure. If there is supraventricular tachycardia or ventricular tachycardia, it should be controlled using antiarrhythmic drugs. And if there is any heart block, it should be controlled using antiarrhythmic drugs or temporary pacing. Now, for treatment purposes, there is a physiological classification of any case of heart failure. So, there are two questions which we must ask in any case of heart failure. First, is there any congestion? Congestive features of congestions are like hepatomegaly, tachypnea, orthopnea, facial pedal edema. If these are present, then there is congestion. And the second question which we should ask is there low perfusion? So, the signs of low perfusion are tachycardia, cool extremities, hypertension, or an irritable child, or a child who is very lethargic. So, if answers to both of these questions is no, then the heart failure is warm and dry type. And this is the ultimate goal of treatment of any kind of heart failure. We want to reach this classification, warm and dry type. However, if there is congestion, but there is no low perfusion, then it is classified as warm and wet. It is very self-explanatory. Because there is no low perfusion, the peripheries are warm, so the type is warm. And because there is congestion, lung congestion, so it is wet, warm and wet. Now, if there is no congestion, but there is low perfusion, then it will be classified as cold and dry. And if both congestion and low perfusion are present, it will be classified as cold and wet. And the most rare, but the most difficult to treat is the cold and dry. This is the most difficult to treat. And this is our ultimate goal, which try to achieve the warm and dry state. And most of the patients will come either as warm and wet or as cold and wet. And there is one basic difference in the treatment of these two conditions. If it is warm and wet, we give diuretics. And if it is cold and wet, first we use inotropes, which is followed by diuretics. This is the major difference. So next up, we'll discuss each type of heart failure, how it is managed. Warm and dry, if the ejection fraction on echocardiography is greater than 40%, then we start with ACE inhibitors, which reduces the cardiac remodeling, and the most commonly used drug is enalapril. And the side effect is dry cough. If there is a lot of dry cough, then we can replace enalapril with any angiotensin receptor blocker like losartan. And if the ejection fraction is less than 40%, we should add ACE inhibitors like enalapril. And apart from that, we should also think of using beta blockers like carvedilol or metoprolol. What they do is that they blunt the chronic sympathetic stimulation of the body and decrease the heart rate, and they improve the diastolic filling of the heart. But remember this point, these two drugs are used only in cases of chronic heart failure. Suppose you have managed the acute part, now the patient is going into chronic heart failure, then only these two drugs are used, not in case of acute heart failure. So the most common subtype is the warm and wet subtype. And the basis of management, the first thing we should give is diuretics. Most commonly we give injection furosemide as 6-hourly or 8-hourly dosing, or as a continuous infusion, which leads to very gradual clearing of the body water. If only furosemide is not working, we might as well as some thiazide diuretics like chlorothiazide or metolazone. And if any form of diuretic therapy is not working, we can also use positive pressure ventilation in these cases, either invasive or non-invasive. Coming to cold and wet. So the difference between warm and wet and cold and wet is the low perfusion. So in case of cold and wet, first we should improve the perfusion using inotropes. Which inotrop? If the patient is hypotensive, it depends upon the BP. If the patient is hypotensive, we should start with injection epinephrine. But if the patient is normotensive or he has normal blood pressure, then we should start either with injection dobutamine or with injection milrinone. Here again, we can also give positive pressure ventilation. What it does, it decreases the venous return to the heart, so improves the pulmonary congestion. And after this, when we are feeling the pulse normally and the BP is normal, urine output is normal, so the low perfusion has been treated. Now what we'll do, we will add low dose diuretics to clear the congestion of the lungs. So we'll again resort to injection furosemide. Now the most difficult to treat and the poorest prognosis is of the cold and dry type. Here we use inotropes like epinephrine, dobutamine and milrinone, and positive pressure ventilation like mechanical ventilation. But in spite of these, we also require circulatory support like veno-arterial ECMO or ventricular assist devices. And here diuretics are not indicated. This is the only type where diuresis is not indicated. So there is a very beautiful treatment algorithm given in the AIMS PICU protocols. That is what I am going to show you now. So here it is. If the type is warm and dry, then we ask 3 questions, like whether the ejection fraction is greater than 40%, and there is no or mild left ventricular dysfunction, and good right ventricular dysfunction. If all these criteria are fulfilled, then we'll add ACE inhibitors like enalapril. But if these conditions are not fulfilled, we will add ACE inhibitors plus beta blockers. Coming to warm and wet. In case of warm and wet, we'll start with diuretics, and if the condition improves in 40 to 72 hours, then we'll again treat as warm and dry. But if it does not improve in 40 to 72 hours, we will treat it as cold and wet. Now coming to cold and wet. In cold and wet, we'll start inotropes. We will use mechanical ventilation. After the perfusion has improved, then we'll start diuretics. And we will just monitor the child. If the child is warm and diuresing in the first 48 to 72 hours, then we will wean the drugs over the next 48 to 72 hours and treat the child later as warm and dry. However, if the condition is not improving, then we will treat him or her as a case of cold and dry kind of heart failure, which is the most difficult to treat and has the poorest prognosis. Here we will also require, apart from mechanical ventilation and inotropes, we will also require circulatory support like ECMO and VAD. Now let us discuss certain drugs used in heart failure. This table is also taken from AIMS PICU protocols. Here we come to know about the different vasoactives like dopamine, dobutamine, epinephrine, milrinone and levosimendan, and the receptors, their effect on the heart rate, cardiac output, systolic BP, half-life, and myocardial oxygen consumption. Here, myocardial oxygen consumption part is very important because all of the drugs increase the myocardial oxygen consumption, which may lead to worsening of the heart failure. However, there are 2 drugs which do not affect the myocardial oxygen consumption. They are milrinone and levosimendan. So these should be used because they don't increase the oxygen consumption by the heart, and also they are lusitropic. They allow the heart to go into diastole. So these 2 are very good drugs. In fact, milrinone is the first line drug in case of warm and wet. In fact, milrinone is the first choice of drug in case of cold and wet where the BP is normal. If the BP is not normal or it is low, we start with epinephrine. However, the dose of epinephrine here is lower than that used in septic shock. Here we go till 0.3 microgram per kg per minute, because up till there it increases the cardiac contractility. Above 0.3, it usually causes peripheral vasoconstriction, which leads to increase in afterload, which leads to worsening of the heart failure. Another very important thing to note here is the half-lives. We look at the half-lives. All the other half-lives are within 2 to 20 minutes, about like on an average 5 minutes. They have very short half-lives. So we can increase the dose or taper the dose very swiftly in case of dopamine, dobutamine, and epinephrine. But in case of milrinone and levosimendan, they have half-lives in hours, like 1 to 4 hours in milrinone and 1 to 1.5 hours in levosimendan. So they take some time to take action, and when we are decreasing or tapering, again, we have to give them some time before we taper the drugs. We have to taper them very gradually. Again, we should know the side effects of all these commonly used inotropic agents. Agents like epinephrine, dopamine, dobutamine, they all lead to tachycardia. And what tachycardia does, it increases the myocardial oxygen consumption and it does not allow the heart to go into diastole effectively. The other two very important drugs, milrinone and levosimendan, the most common effect or side effect is hypotension. Hypotension, yeah. So here, first we should ensure the patient has normal BP, only then we should add milrinone or levosimendan. Coming to mechanical circulatory support, there are two forms, ECMO and VAD. First we will discuss about ECMO. There are two types, VV ECMO, but it offers only respiratory support, and there is a VO, veno arterial ECMO, which is for cardiorespiratory support. And this is the VA ECMO is the one used in heart failure. Components are tubings, an oxygenator membrane which acts as the lung, and a pump which acts as the heart. These ECMO and VAD are bridge therapies. They are not like it is a bridge therapy to some destination, like bridge to recovery. In cases of myocarditis, when the heart recovers, it's a bridge to recovery. Or bridge to transplant, when we expect the patient will need a heart transplant, then it acts as a bridge to transplant. Then bridge to bridge. If ECMO has to be changed into VAD, because VAD is also a bridge therapy, so it is called bridge to bridge. And sometimes we know that this condition is incurable, so it will not benefit from heart transplant also. So that is known as bridge to nowhere. ECMO is offered as a last resort therapy. There is a very popular dictum, like think about ECMO risk if the risk of mortality is greater than 50%, and initiate ECMO if the risk of mortality is greater than 80%. However, there are some challenges in cases of ECMO treatment, like awareness. People are not aware, even doctors are not very aware about the use of ECMO. Availability of infrastructure and trained professionals is lacking, and high cost of purchase and maintenance. Talking about the cost of ECMO in India, the machine cost is about 35 lakhs. The circuit cost is about 3 lakhs. But in India, they make some customized circuit in these in the hospitals which are doing ECMO, and they make it at around 10,000 rupees. However, the cost of ECMO in India is much lesser than that of the developed nations like USA and UK or European countries. The cost is about 1/3 of that of Europe and about 1/4 of that of USA. And there are certain hospitals who are running ECMO on a no profit, no loss cost, like Riddhivinayak Hospital Mumbai and the Anand Hospital Pune. And due to this, the cost of ECMO in these hospitals is much lesser than in other hospitals. What they charge is about 1.5 lakhs for initiation of the ECMO and 10,000 per day for running the ECMO. Here is a visual representation of what an ECMO does. So it totally bypasses the pulmonary blood, and the blood from the right atrium goes into the pump, which is acting as the heart. And from the pump, it is going to the oxygenator, which is acting as the lungs. And from the oxygenator, it is going into the aorta. So it is totally bypassing the pulmonary circulation, and it is taking up the function of both the lungs and the heart. Here is what an ECMO looks like in a hospital setting. But this is a picture of a VV ECMO. In cases of heart failure, we need a VA ECMO or a veno-arterial ECMO. Coming to VAD or ventricular assist devices, they offer only circulatory support and no respiratory support. So if the child is suffering from only cardiac dysfunction, we can use VAD. However, if the child is suffering from cardiac plus respiratory problems, then we cannot use VAD. We have to use VA ECMO. Here, the cannulation is done by a sternotomy into the left atrium and to the ascending aorta. So it is very much more invasive than ECMO because sternotomy has to be done. And there are various types of VAD like extra, para, and intracorporeal, which means outside the body or on the body or inside the body. And there is short-term and long-term VAD. If we believe that the disease process will resolve in a very short amount of time, so we use very less duration of VAD, it is known as short-term VAD. And if we use it for prolonged durations, it is known as long-term VAD. Now again, if it is supporting only the left ventricular, it is known as LVAD or left ventricular assist device. Or if it is supporting both the left ventricular as well as the right ventricular, then it is known as BiVAD or biventricular assist device. Again, VAD is also bridge therapy because we should know what destination we are aiming for. Like it can be a bridge to recovery if the heart condition improves, and it can be a bridge to transplant. Like if the candidate or if the child is a candidate for transplant, heart transplant, it can bridge the child to transplant, or it can be a bridge to destination where the child cannot be transplanted a new heart. So a long-term VAD is used for a very long duration of time and the child is supported on long-term VAD. Here is an example or pictorial representation of a left ventricular assist device. So they can wear it and roam about also. This is long-term VAD. We can see that the LVAD pumps blood into the aorta and to the body. Here the aorta is cannulated and blood from the left ventricular enters the LVAD. Here the left ventricle is cannulated. Here is an algorithm of how to proceed in case the child requires a mechanical circulatory support in the form of ECMO or VAD. Well, first we should see whether there is hemodynamic instability or cardiac arrest or lung dysfunction. If it is not there, then we can use VAD. However, if it is there, then we cannot use VAD. We have to use VA ECMO. However, if there is inadequate recovery from VA ECMO, then we have to shift to VAD. Now, what kind of VAD? If there is a potential of recovery, then we used short-term or temporary VAD. Or if there is no potential of recovery, we have to use a durable long-term VAD, which will ultimately either lead to heart transplant or to death. Even VA ECMO can either lead to either the death of the patient or it can lead to the recovery of the patient, and it may also need to be transplanted later on. So this is the algorithm. So the key takeaway points from this presentation would be we should always have a high index of suspicion in case of heart failure because the symptoms and signs are very vague. It can lead you to think that this is due to some respiratory cause or due to some GI cause, but actually it is a case of heart failure. Again, you should always remember the ways to decrease the oxygen demands because this is the most overlooked step. We should manage the fever. We should keep the patient sedated. And complete bed rest, head and elevation. We should aim for all these things. And we should quickly classify them into wet and warm and dry, warm and wet, cold and dry and cold and wet because the treatment modalities differ. The algorithms differ in case of all these subtypes. And we should not overuse inotropes in very high doses. Like if we go beyond 0.3 microgram per kg per minute in cases of epinephrine or adrenaline, it leads to too much increase in heart rate, which will not allow the heart to go into diastole, and which will increase the myocardial oxygen demand, and all these things which will lead to aggravation of the heart failure. And we should also know ways to assess the preload, contractility, and the afterload through clinical means and by doing bedside echo also, for a very targeted approach, whether to target the preload or the contractility or the afterload to improve the heart failure. So that was all about this presentation. Thank you for being with me, and see you in the next class.